So there's actually a large team of other researchers who are working with me, including a few St. Mike's researchers named on the slide, Daryl Tan, Ahmed Bayoumi, and others. So I just want to acknowledge them. We've been actively looking at STI co-infection among people with HIV, and especially men who have sex with men who are living with HIV in the cohort for a few years now. And this cohort, who here has heard of the OHTN cohort study? If you could raise your hand, if you're familiar with it. Okay, so about half of you. This is a really large cohort of people with HIV. I'll describe more about it as we get into the analysis or talking about the data I'm sharing. But there's like a cast of thousands that support this cohort, and I just wanted to recognize them as well, including our investigators, volunteer members of our governance committee, and people working at the clinics where we collect data. So what I wanted to talk about in the next, about 40 minutes, I guess. That's about usually your amount of time.
Yeah.
And then, okay.
Yeah.
Right.
Take your time.
Take my time.
Take time for questions would be great.
Okay. I want to first talk a little bit about these overlapping epidemics of syphilis and HIV among men who have sex with men, so kind of the bigger picture of why this matters. And then I'm going to talk about findings from the OHTN cohort study as they relate specifically to men who have sex with men who have HIV. How common is it that they get tested for syphilis? How common is syphilis co-infection? What are the risk factors for a new diagnosis of syphilis among these men? And then some very fresh data, hot off the presses, you're the first group to see it, is going to be what's the evidence around viral load changes at the time of syphilis diagnosis. And then I want to end about talking to you about a new study that St. Mike's is one of the participating sites where we're going to look at a trial to improve syphilis screening among HIV-positive men who have sex with men. So you've all heard that syphilis rates are up. You see this in your patients. It's not unique to Toronto, nor to Ontario, nor to Canada. It's been happening in urban centres internationally, even outside of thinking of North America and Europe. There's many new studies coming out of China, for example, that are seeing a lot of outbreaks of syphilis among men who have sex with men there. And very often, a lot of the syphilis outbreak and cases are occurring among men who also have HIV. So some of the things we might want to be thinking around, right, why syphilis among men with HIV might be important. Of course, we want to detect it as early as possible for some more simple treatment as opposed to more complicated treatment. It's also easier for the men to have one single shot of penicillin compared to IV penicillin for many days. It's less expensive. There's some concern that if you have HIV and there's a syphilis co-infection, that maybe you'll be more infectious. Certainly, if you have syphilis, you might be more susceptible to HIV if you're exposed to it. There's some concerns that maybe treatments are more difficult among men with HIV, treatment for syphilis, that is. So these are all some of the reasons that get discussed as why these two overlapping epidemics matter. Here are data now from Ontario, not yet getting into the cohort, just looking at what are the reported cases of syphilis. And here you can see what are the number of cases and rate of new cases of infectious syphilis per 100,000 population, going from 2000 to 2013. So in blue, you can see the blue bar is the total number of new syphilis cases among men. And then you can hardly see the green bar. These are the number of female cases. Essentially, you need a magnifying glass to see the number of green cases. This is largely outbreaks among men. And if you look at the line that's happening here, this is the rate per 100,000 population among males in Ontario. And you can see that kind of shot up. The earlier part of 2000 dipped a bit and then ramped up again. And you will see as we start to look into the cohort data, that very similar pattern of going up over those calendar years, we're going to see it among men with HIV as well. Now, when you go in and you actually look at the risk factors that are reported by new cases of infectious syphilis in the province, you can see that the percent MSM among male cases has climbed up quite a bit to about the vast majority, around 80% of new cases among men, they are men who report sex with men. An HIV infection is also present in these male cases in nearly half of them. We think that's an overrepresentation of HIV-positive men in these syphilis cases because HIV prevalence, as best we know from MTRAC surveys in Toronto and Montreal, is that HIV prevalence is somewhere between 10 to 20 to 25% in the population of gay and other men who have sex with men. So when you see nearly half of syphilis cases also having HIV, that's an overrepresentation of HIV-positive men. So all of this data in the background, this international data getting shared and reported, and certainly what we're seeing in Ontario and most of these cases happening in Toronto and Ottawa, we thought, okay, this needs to be explored among people with HIV. What are the rates, etc. So we have available to us data from the OH10 cohort study. So this is a study that has had many different forms over the last nearly 20 years, but it has, in general, recruited people who have HIV, adults, who are getting care at specialty HIV clinics across the province. To date, over 6,000 people have enrolled in this cohort, and people who are participating in the cohort represent about 1 in 4 of everyone actively getting viral load testing in the province. So it's a fairly substantial slice of the overall population of people in HIV care. We get a lot of information on the participants in the cohort. For all the years that the cohort's been running, we've been getting information from medical charts. And then later in time, around 2007, 2008, we started annual interviews, and we also do record linkage with Public Health Ontario laboratories, which is really important for what I'm about to share with you because PHO Labs is the sole provider of syphilis testing in the province. So what that means is through record linkage, we know if men have been tested, or anyone in the cohort has been tested for syphilis, whether or not that order for syphilis testing took place at the clinic where they're participating in the study or by any other provider in the province, including if they go to a place like Hassle Free. We bring it in. And here is just a snapshot, a map of where all the different clinics that are participating in our cohort. So we have pretty good representation across the province and 4 participating sites in Toronto specifically. So who's in the cohort? Around 80% of people who've ever enrolled are male. In lighter blue, you can see this is the proportion who have ever enrolled in the cohort. In darker blue, these are people who were still actively participating in the cohort as of the end of 2012. So, good number are men. And then if we look on the right-hand side of what exposure category or HIV risk factor do people report, about 2/3 of are men who've reported sex with men as an HIV risk factor. So all in all, about 2 in 3 participants in this cohort are men who have sex with men. So we have a pretty sizable population, a couple thousand of HIV-positive MSM in the cohort. On average, these men report white ethnicity, but we have reasonable representation of other races and ethnicities, such as Indigenous or Black, African, or Caribbean. On average, men were diagnosed with HIV in their early 30s and are now nearly 50. So they're about 47, 48 years old as of their last follow-up. And on average, most of them are doing fairly well in terms of their CD4 cell count. The mean CD4 cell count that we last know about is over 500. I also want to talk a little bit about where they're at in their engagement in HIV care, being on treatment, having suppressed viral load. Have people been hearing about the HIV Care cascade in your work? So this is a pretty big thing. It's kind of a lot of excitement around this new idea in 2012, and it's really become entrenched in a lot of HIV surveillance work and clinical work, trying to see how many people are in care and retained in care on treatment and suppressed. And that's what I'm showing you here from all MSM who've enrolled in the cohort, going from 2001 to 2011. In black, it's a proportion who had at least one HIV care visit in the year. In blue, at least 2 HIV care visits at least 3 months apart. In yellow, they're on antiretroviral treatment. They've initiated it. As far as we know, they haven't stopped. And in green, last viral load in the year was undetectable. And you can see that we've had a really dramatic rise in that green bar has really gone up. The proportion on ART has gone up, which is explaining why more and more people are undetectable. But by the end of 2011, 80% of MSM in the cohort have started and have stayed on therapy, and 77% have undetectable viral load. So the majority are men in HIV treatment doing well. I want to talk a little bit about their sexual behavior. Of course, we're going to talk about an STI, right? Syphilis. So we want to know how sexually active are these men. We added a self-completed questionnaire to the annual interview. In 2010, 2011, men self-complete this on a tablet. And they're asked about their behavior in the preceding 3 months. So these are data from the first time men filled out this questionnaire. And you can see that about a third of men don't report being sexually active with a partner at all. That's the lighter color here, the aqua color, 37%. Whereas 13%, the top in black, have reported sex with at least 5 partners in the preceding 3 months. And now these next two bars are about how many HIV-positive partners did you have in those 3 months, and then how many HIV-negative or status unknown partners did you have. So what you can see is that men seem to report more HIV-negative or status unknown partners if we just kind of compare those last two columns. But there is some serial sorting going on, that positive men are having sex with other positive men. I want you to watch that 5% of men reporting sex with at least 5 other HIV-positive partners. It's a small proportion, but it's going to turn out to be a very important one for syphilis. So I've talked here a little about the serial sorting already. We see that after you take into account about 37% of men have no partner in the preceding 3 months, about equal proportions are reporting sex with only other positive partners, only negative or status unknown, or a mix, with the largest proportion being that darkest color, 34.5%, who report a mix. In terms of their anal sex behaviors, about 2/3 of the cohort are reporting, no, that's wrong, a little less than half are reporting engaging in anal sex behavior. 17% are reporting that they have a sexual partner but don't report anal sex. And 18% always use condoms with their partners, as opposed to about a quarter saying at least some condom with sex, of course. So some risk is occurring potentially for syphilis transmission, but not all men in the cohort would we say are at risk, given that about a third are not reporting a sex partner. So now, how common is the testing for syphilis? We published this a couple of years ago, so I'm sharing with you a little bit of updated data from that publication. So what you can see here is we went from almost nobody in the early 2000s getting at least one syphilis test a year to about 55 to 60%. You see this gradual rise, a bit of a plateau and a bit of a rise up again by 2013. Now, guidelines for testing for syphilis vary depending on where you're looking. In the Canadian guidelines, certainly gay men and other men who have sex with men who are at risk, at least annual testing, and even more often than annual if you're at ongoing risk, but not really clear instruction on how often should you test people with HIV in general. Whereas US guidelines suggest everyone with HIV should get at least an annual sexual health screen, including testing for bacterial STIs. If you go to the UK, everybody with HIV, no matter what kind of sexual behavior they report, should have syphilis screening every viral load. It's much more involved. But you might be wondering, well, that other that part at the top there that are men who are not getting tested for syphilis, maybe those are just the men who are not sexually active. So we can go in and take a look at that and look at what proportion of men, according to the partners they reported in the past 3 months at their first sexual behavior questionnaire that they filled out, sometime usually in 2010, 2011. And we look forward in time, okay, who got a syphilis test? On average, we're looking forward in time about a year and a half. And we can see that the more partners that men reported, the more likely they were to subsequently get a syphilis test. But still, we found even the men who reported 5 or more partners in that 3-month period, 22% of them were not tested for syphilis in the subsequent year and a half. So there is some sign there that people at more risk are more likely to be tested, but still maybe we could do a little better there. We found that testing at least once a year was most common among the young men who tested before. So if you've tested before, you're more likely to get tested again. And men who had more HIV clinic visits in the year, more likely to get tested. I guess more opportunity to have been tested, more opportunity to have presented with symptoms as well. On average, people who tested got tested once a year. And this was interesting. We didn't quite know where all the syphilis testing would be happening. And initially we thought, well, maybe men would be more likely to go to hassle-free or places like that for their syphilis testing. But we actually found that the majority of tests were ordered by HIV care providers and not by sexual health centers. And that suggests that HIV clinics might be a place we want to think about for any interventions to get even more screening for syphilis or other bacterial STIs. So now let's look at how common syphilis was. This particular, I don't know if you can see this. This is, I love some of these kind of retro posters from the First and Second World War. It says, syphilis, all of these men have it, women stay away from dance halls. So we observed as of 2009 that it looked like about 1 in 4 of all HIV-positive men who have sex with men have had at least one reactive syphilis test, suggesting at least once in their lifetime they've had syphilis. As opposed to if we look at the other men who are largely heterosexual men or women, far lower proportion. And most of the reactive tests where virtually all of them really, where we would see syphilis tests with high RPR titers, it's in the MSM. It's not in the women. Women, when the syphilis test was run, it looked like past and treated syphilis. These are actually showing you incidence of a new diagnosis of syphilis per 100 person years from 2006 to 2010. In yellow, this is the first diagnosis as best we know it. So these are people who had a negative syphilis serology followed by a reactive one. Then re-diagnosis is in blue. So these are people who had a previous negative, but very low titer syphilis serology. And then we look to see do you have at least a 4-fold rise in RPR titer subsequently. So that's what we're calling a re-diagnosis. And then in green is simply combining those two together. So you can see that re-diagnosis is far more common than first diagnosis, but these are still fairly high rates. So we're going from about 2 new diagnoses per 100 men per year to around 4 new diagnoses per 100 men per year. And compare that to the general population rate among men in those calendar years was around 10 per 100,000. So this is quite a bit higher. So now risk factors. We've done some work looking at kind of just sociodemographic factors associated with syphilis diagnosis risk. And I'm going to share with you in the next slides sexual risk behaviors. So we've seen that people most likely to be diagnosed with syphilis are the younger men. We also saw statistical evidence there for that rise over calendar time, that rates are going up. We find the highest rates are among men attending care in Toronto, then after that Ottawa, and then after that any other places in Ontario. Men who've been diagnosed with syphilis in the past, nearly 5-fold more likely to get diagnosed with syphilis again. And we also found there that men who had detectable viral load, which is largely men not on treatment, were about 40% more likely to have a new diagnosis of syphilis. So I do want to emphasize here, this is all just from record linkage with syphilis tests that were ordered for patient care. We don't do any blood collection in this cohort. It's not like that's what we would ideally like to do, to really know what the syphilis infection rate was. We would have bloods from everyone. This is just based on what was actually ordered. So in all likelihood, rates could be even higher than this, right? Because we may be missing some asymptomatic cases. So now let's look at sexual behavior and who was more likely to get a syphilis diagnosis. This is, I think, even more of interest in thinking about how are men getting it and how might we want to frame prevention, messages, health promotion, etc. So, number of sexual partners is a known risk factor for STI, and it's definitely coming through in these data. So here we're looking at HIV negative or status unknown partners reported in the preceding 3 months. This is a baseline sexual behavior questionnaire. Now looking forward in time and seeing what percent had a diagnosis with syphilis about 1.5 years to 2 years afterwards. So the more partners you reported at baseline, these are HIV negative partners, or partners for whom we don't know, that the man did not know the status of them, there's this increasing risk. But watch how this moves when we start talking about the positive partners. You see how much that shifts up. So a whole lot more risk depending on number of positive partners that men reported, such that over 25% of the men who reported 5 or more positive partners at baseline had a subsequent syphilis diagnosis about 1.5 years to 2 years later. That's a pretty high proportion. And now looking at it by the kinds of sexual activities men engaged in. So we see that men who reported no partner at baseline, it wasn't a zero rate because of course that could have changed later, right? They maybe had a partner a few months afterwards, but this is what they reported at baseline. Sexually active but no anal sex, still about 4% of those men have a subsequent syphilis diagnosis. If you have anal sex always with a condom, it goes up even higher. Some condomless anal sex is the highest risk category, with about 13% of them having a subsequent syphilis diagnosis. Now, these are results from a Cox regression, where we're looking at time to a new syphilis diagnosis. And here we're taking into account all the information about the sexual behavior that men report. So not just their sexual behavior that they report at first questionnaire, but if they do the questionnaire again a year later or a year after that, we update that information in the analysis. And what we see are the strongest risk factors for new diagnosis of syphilis. It's the number of positive partners that men report. Definitely 5 or more HIV-positive partners in a 3-month period, nearly 6-fold higher likely diagnosis of syphilis. It's a very strong association. Meanwhile, once we account for that, for the number of positive partners that a man has, the risk that's posed with the number of negative partners that a man has, it actually goes to null. Meaning, no additional risk informs the data by knowing how many negative partners men have had. And then if we look at the types of anal sex behaviors, basically engaging in anal sex, whether you use a condom or not, risk for acquisition of syphilis has gone up over 3-fold. Okay, now here's some of the newer data that I was talking about, so feedback on this is especially welcomed. So I mentioned at the beginning that some of the reason we are concerned about the syphilis HIV co-epidemics is that if you have HIV and you get syphilis, there's the supposition that your viral load will go up, you'll be more infectious. Of course, we're not, for this route of transmission, we're really thinking about HIV viral load and seminal fluid, rectal fluid, because that's where the transmission is going to occur. But there's this concern that, viral load will go up. And then a lot of that information that informs that hypothesis or the evidence around it comes from antiretroviral naive people with HIV, or years ago when the therapies weren't anywhere near as effective as they are now. And you see that, on today's therapies, virtually all the men, over 90% actually, in our cohort who are on treatment have viral suppression. So in modern ART times, do you see this rise in viral load? Well, we don't have semen, we don't have rectal fluids to test for viral load at the time of syphilis diagnosis, but we can take a look at least at plasma viral load. So that's what we've done here. And we kind of went back from the time of the syphilis diagnosis and see, well, what happened about 6 to 12 months before? Where was the viral load at then? And what's their ART status? And basically what this box and whisker plot is telling you is that men who are on ART for at least a year and had undetectable viral load about 6 to 12 months before their syphilis diagnosis, when we look at what their viral load is at the time they were diagnosed with syphilis, it's still pretty low. The vast majority are actually undetectable. Only 5% of those men have detectable virus in plasma. And then the next category is they've been on treatment for over a year, but they actually did have detectable viral load, at least 1,000 copies or more, 6 to 12 months ago. Well, they're a bit more likely to have a higher viral load at the time of syphilis diagnosis. For the men who have high viral loads at the time of syphilis diagnosis, largely, these are men who are ART naive. They're men who started less than a year ago, or they've been on ART but had higher viral loads 6 to 12 months ago, suggesting they're having challenges with adherence. Does that make sense? So, as I mentioned, men who are on ART for at least a year, who've had past suppressed viral load, 95% of them undetectable plasma viral load at time of syphilis diagnosis. For the men where we found a detectable plasma viral load when they were diagnosed with syphilis, most had detectable viral load before that diagnosis. A good portion, nearly 40%, were naive, or they were recent initiators. And for the men who were on ART, a good portion of them report some non-adherence, suggesting that it's more around whether or not you're on ART and whether or not you're adherent, whether or not they had detectable viral load, and not necessarily the syphilis. So we don't have, as I said, we don't have seminal fluid, we don't have rectal fluid to really say without a shadow of a doubt is good evidence that they might not be more infectious even when they have syphilis. But I think this is promising to follow up with. One more thing there that we did take a look at. This was we looked at all the men in all the gay and other men who have sex with men in the cohort who went on treatment and who got to successful viral load suppression. And then we looked forward in time and looked at time to virologic failure. And then we looked at, is there an elevated risk for virologic failure if you've had syphilis? So the blue line there is time to virologic failure for people who've not had a diagnosis of syphilis, and in red it's the men who have had an active diagnosis of syphilis, and this is kind of time updated, taking into account when that syphilis diagnosis occurred. And essentially the blue and the red lines are not that far apart at all. They're pretty much together, and when we actually compare hazards for virologic failure, there's no additional risk posed by syphilis diagnosis. So I want to talk a little bit about the strengths and limitations of the data from the OHTN cohort study and what I propose these findings might mean, and then I'll finish up with talking around the new trial around syphilis screening. There are a number of strengths we can note. One is this is a fairly large sample of men who have sex with men who have HIV. So there's over 2,000 men in this cohort. Good representation across the province. And in general, in the OHTN cohort study, in terms of sex, age at diagnosis, where people live, an HIV exposure category, the people who are in our cohort are very similar to the people who have ever been diagnosed with HIV in the province. So that's good. And because we have this data sharing agreement with Public Health Ontario, we're really able to ascertain well who got tested for syphilis. But there are limitations. We do know that people in the cohort underrepresent younger people living with HIV. I mentioned to you at last follow-up, on average, these men were 47, 48 years old. Very small proportions are under the age of 30. And we know that's where more syphilis diagnoses are occurring. Even within our own data, that's where the highest risk is. From comparisons that have been done with in clinics where we've been able to look at, okay, among your clinic patients, who's in the OCS and who isn't, we know that people who participate in the study first do get approached to be invited, and then who agree. They tend to be healthier than people who are not approached or who do not agree to participate. And they're better engaged in HIV care too. They tend to have, more often they're in continuous care, more likely to have suppressed viral load. I've mentioned already that these were syphilis tests that were ordered for routine patient care purposes. And we know our sexual behavior measures are incomplete. So men were asked about things they did in a 3-month period, and then a year passes and we ask, okay, now what happened in the past 3 months? We're missing 9 months. There's also other kinds of behaviors that might pose risks for syphilis. Like we didn't ask anything about oral sex partners, for example. So that's just something we don't know. So all in all, we think that what I just shared with you probably underestimates the true rate of syphilis acquisition among HIV-positive men who have sex with men in Ontario, due to the fact that it's not all men, we're missing younger men, and we haven't tested everybody. So in terms of what are the most important risk factors to be thinking about for patient counseling or thinking about who might need a syphilis test, definitely men who are reporting sex with lots of other positive men are at risk. And we actually see that about 19% of new syphilis diagnoses occurred in the 5% of men reporting 5 or more positive partners in a 3-month period. And we're just not seeing additional risk from how many negative partners or status unknown partners that men report, really suggesting that a lot of the, at least for now, don't know how this might change with PrEP and other behavioral changes, but at least for the years studied, a lot of the transmission that was occurring, syphilis transmission, was occurring in pause sexual networks. So that's potentially a good thing in the sense of there's less opportunity for the syphilis to have potentiated further HIV transmission. It also suggests that if syphilis control efforts are really targeted to men who are HIV negative, we're going to miss a good portion of the population who really need help. And I do want to say that even though we didn't see additional risk from sex with negative partners, that the bridging can still happen. And a good portion of men who reported positive partners also reported negative partners. And as PrEP starts to become more common and maybe men serosort less, this could be an issue to watch for ongoing syphilis transmission. Okay, we do wonder about syphilis transmission that could have occurred due to oral sex. We did see some transmission occurring among men who diagnosis occurring among men who denied anal sex behaviors. And there didn't seem to be a big difference in whether, for men who did report anal sex, whether or not you got a syphilis diagnosis didn't vary much, depending on whether you reported sex with condoms or sex without. We do see from these data that it looks like the syphilis epidemics have become, they're not targeted to one very narrow sociodemographic group. It's not just young men under the age of 30 living in Toronto. Even though the higher rate is among the younger men in Toronto, we're still seeing rather high rates, even in men over the age of 50. we're seeing about 2% of men over the age of 50 are having a new syphilis diagnosis per year. And again, bring that back to the general male population, it's about 10 per 100,000. So this is really suggesting that a broad-scale intervention might be needed, something where we're really trying to target a very narrow group. Could be effective, but not as effective as what maybe we need it to be. So we are going to try something different in terms of syphilis testing. This is a new study called the Enhanced Syphilis Screening Among HIV-Positive Men study, or ESAM. And what we want to do is try rolling out routinized syphilis testing with HIV viral loads. So we have 4 hospital sites, HIV clinic sites, that are going to participate in this trial. It's a cluster randomized control trial where we're randomizing the clinics to order of rollout of routinized, but basically routine standing orders for syphilis testing whenever viral loads are done. And there is going to be a process evaluation component as well as a health economic component. We want to see if the additional cost from doing this is an effective use of resources. With this intervention, we want to look to see does routinizing syphilis with viral loads increase the proportion of men who undergo at least an annual syphilis test? Does it shorten the interval between tests so we get more frequent testing? It should. On average, men get 3 viral loads a year. And do we get more detected cases of syphilis, particularly those asymptomatic cases that might not have been picked up?
What's your control here?
Basically, the clinics are their own control. So everybody gets a kind of status quo follow-up for a period, and then we slowly implement the intervention over time so that, and then at the end, everybody gets a period where they've implemented the intervention. So we can do pre-post within the individual clinics, and we can also compare the clinics who have not been randomized yet to roll out to the ones that have now been randomized to roll out. That's the idea of the stepped approach. So the findings I shared with you today definitely have informed this new study. There've also been promising results from the Australia and the UK that standing orders for syphilis testing with viral loads did well in increasing all those things in terms of the proportion of people who get tested, more frequent testing, more cases detected. But all of the other studies that have done it have used uncontrolled designs, kind of pre-post designs. So we're amping up the rigor of our design a bit more. We also, in looking at surveys, not in the OCS, but other surveys of healthcare providers and people living with HIV, it seems that having standing orders is something that be welcomed by healthcare providers. It takes some of the burden of thinking of, does this patient versus another need syphilis testing or not? And men often say that what prompts them to get a syphilis test is that their doctor suggested it. And there's also been some mathematical modeling work done that really suggests that you can have a huge impact on controlling the syphilis epidemic in a population by increasing frequency of testing. So doing one-off tests aren't enough. You can actually get rebounds in syphilis epidemics, but if you get populations at risk repeatedly testing for syphilis, the fact that they get detected and the presumption is they are successfully treated then, you'll really reduce population transmission. This could be an inexpensive, practical way to go about it. And there are still some things we're not so sure of. I think it's a really good idea that we're still doing the trial. So one of them is that we know that there is a move to do less frequent viral load monitoring, particularly for the patients who are doing well. So for an intervention like this, where syphilis testing is tied to HIV viral load monitoring, that may mean that the potential impact of the syphilis intervention might not be as much as we would have liked. And if the interval for syphilis testing gets too wide, you don't get that population level benefit. And an intervention like this is handy in the sense that For men in HIV care, they're already in care, they're kind of a captive audience, so that's a good thing, but it doesn't really address the population of men who are not in care or who are in very infrequent care. So we're going to be watching for all those things in the intervention. And things look good, we'll then hopefully support a move to scaling up. So that's all I had for you today, and happy to answer any questions, any thoughts you have.
I thought that was excellent, very clear, and it's great work. I have a couple questions. One is, when we're seeing patients in the clinic, the first thing that, and I'm sure Charlie and others would agree, that we think of when we think of syphilis, that what's fueling it is drug use. And I noticed that, and I don't know if it was a methodological issue in terms of trying to capture that, or I wonder if you have any data looking at what drives the number of sexual partners, because in working with patients, I suspect that a lot of it is fueled by drug use, specifically crystal meth, and I know there's been some work in that.
Mm-hmm.
So I wonder if you have any comment on that.
I haven't specifically looked at what predicts a higher number of partners in terms of drug use, but some of the work that our group has been doing has been trying to pull in the drug use information to see if there's an additional risk posed by drug use once you've accounted for the sexual behavior. Not just for syphilis, but also for chlamydia and gonorrhea, because we've done that work too. And essentially the risk factors are the same for chlamydia and gonorrhea. And we find there that even after accounting for the sexual behavior, drug use predicts chlamydia and gonorrhea diagnosis. We have to check it now with the syphilis as well. So I think it's kind of it could be a core group of a sexual network where there's a lot of drug use happening, a lot of positive sex happening. That's where the STIs are getting concentrated. So you do have this overlap.
And that was great.
Okay, thank you.
So much.